Hello. So today we're going to talk about syncope. The objective for this lecture including factors, including the factors that may lead to syncope in older adults, elements of the evaluation, including history, physical examination, testing of older adults with syncope, and treatment options for syncope. And here are all the topics we are going to cover in this lecture. So the definition of syncope is a kind of a symptoms complex composed of a sudden and transient loss of consciousness resulting from a temporary interruption of global cerebral perfusion. And it's a common reason for evaluation in both outpatient clinics, ED, and for hospital admissions. And it annually accounts for approximately 1 to 3% of ED visits and 2 to 6% of hospital admissions. The incidence of syncope increases with age. So if patient older than 70 years old, the incidence is doubles. While if patient older than 80 years, more than 80 years old, the incidence will be 3 to 4 times higher than the young adults. And about 80% of patients hospitalized for syncope are older than 65 years old. The potential cause range from benign to life-threatening. So in the older adults, the syncope can often multifactorial, and the diagnosis is extremely difficult. The common cause of syncope, including the first one is reduced cardiac output, which is kind of life-threatening conditions. So in order to better understand it, first I want to go through the physiology of cardiology first. So we all know that cardiac output is determined by heart rate and stroke volume. And the stroke volume is further determined by cardiac contractivities and preload. So if any of this has a problem, it can definitely affect the cardiac output, further cause the syncope. So as we can see here, if heart rate has problem, including like if patient has tachycardia, bradycardia, AV blocks, or chronotropic incompetence, that can definitely decrease cardiac output and further cause syncope. And if patient have some structural heart diseases like aortic stenosis, hypertrophic cardiomyopathies, myocardial infarctions, this can definitely decrease patient cardiac contractivities and further cause the syncope. And also if patient has reduced intravascular volume, like bleeding, dehydration, or pulmonary embolism, all of this can decrease the preload, which can also cause the syncope. And so another reason to cause a syncope is altered peripheral vascular resistance. For this one, it contains two classifications. First one is functional autonomic reflexes, and vasovagal has a high chance, high prevalence. So for the vasovagal, so this one normally is stimulated when there's some stimulators from outside, like if patient has any pain or stress or anxiety, it can first stimulate the sympathetic nerve, and first which can have a reflex on the vagus nerve and cause decreased heart rate and decreased peripheral vascular resistance and cause low blood pressure and further cause syncope. So this vasovagal actually is pretty common in the young woman, and also it's also common in the older adults who is having the IV injections or any other pain stimulations. Or the patient who in the cath lab after the PCI procedure, when the anesthesia went off, the pain comes back in the arms, in the wrist, and this can also cause vasovagal. So whenever you saw those patients, especially the patient in the hospital after PCI procedure, so you can identify it by checking their heart rate and blood pressure, which both decreased. And in that case, we normally give patient atropine 0.5 milligram, and also give patient enough fluid, like a 500 cc or 1 liter of saline, and try to fight against with vasovagal, which can decrease both heart rate and blood pressure. So normally the patient will get recovered pretty soon if you inject those medication and give patient enough fluid. Well, in the outside, like in the clinic, if you see patient have vasovagal, normally those patients have a prodrome, like a few diaphoresis, or if some patient has a flushing feeling in their face, on their face, and so in that case, a patient also has some dizziness. Before syncope, you should let patient lie on the floor, raise their legs in order to let blood come back to the heart, and also you can also use ice pack on their to put on their head to calm down the patient. Anyway, we can we'll talk about this later, and I just want to give you an idea of the vasovagal. And for the carotid sinus syndrome, it's actually it's about it means that if this one's including carotid sinus hypersensitivity, and which means that the carotid sinus baroreceptor are very sensitive. So a little bit pressure can make it think it's a high blood pressure, and in order to decrease the peripheral vascular resistance through the nervous system, and to decrease blood pressure and cause syncope. Situational ingress swallowing, micturition, defecation is a similar effect as effects on the vagus nerve, try to on the peripheral nerve system, try to decrease the peripheral vascular resistance. But the mechanism actually was not very well studied for the postprandial hypotension. So I think that after eating, most of blood will accumulate in the GI system that can cause low blood pressure in the system, and further cause depression, cause syncope. For the structural autonomic insufficiency, which including primary conditions like pure autonomic failure, multiple system atrophy, Parkinson's disease, secondary conditions including diabetes, spinal cord lesions, or uremia. All of this can cause peripheral neuropathy, which controls vascular system, especially peripheral vascular system, to adjust the blood pressure. If this nerve system has a problem, definitely it can alter peripheral vascular resistance and cause low blood pressure and further cause syncope. Drugs causing reduced cardiac output, alter peripheral resistance can also definitely cause a syncope. And the mechanism is pretty easy to understand after we went through those physiology of cardiology. So initially decreasing cardiac output or peripheral vascular resistance, which can decrease the blood pressure and reduce cerebral perfusion, cause syncope. And the causes may be benign or life-threatening, and may be multifactorial, and must consider adverse effects of drug as a cause, especially for older adults. For the seizures, actually it's no longer categorized as a cause of syncope because it's not mediated by decreasing cerebral perfusion, and also it's important to differentiate from seizure to syncope, and both seizure and syncope can cause convulsions. So here the table help us to differentiate from seizure and different kinds of syncopes. So as we can see that in a seizure, so during the syncope, it can the muscular tone can be increased, and the pulse can be increased, and also patient sometimes has a fecal urinary incontinence. And also, if you check their eye, can have tonic eye deviation. The eye just pivot every kind of all directions, and our patient also have oral frothing, and so the seizure normally lasts about 4 or 5 minutes, and also after that the patient normally has disorientation. It doesn't know where it is and doesn't know what's going on there, and also patient definitely has some focal neurologic findings if they do image studies or any EEG studies. And for the cardiac syncope, normally patient before the syncope patient have palpitations, and also during syncope patient have their muscle tone actually decreased, and also patient under the episode normally is no longer than 1 minute. Patient can get recovered pretty soon, and after getting recovered, they don't know what happened. And also for the vasovagal before syncope, patient normally have prodrome, as we talked, and sometimes patient has some flushing feeling there on their face. Some patient feel nausea and even vomiting sometimes, and it lasts. And also some patient have blackout in their eyes, and also some patients have diaphoresis. And during syncope, it's pretty similar to the cardiac syncope. And after the syncope, some patients also have some nausea, diaphoresis. So the prognosis of syncope really depends on the underlying cause. Cardiac cause have the worst prognosis, 1-year mortality of 18 to 33%, with deaths chiefly due to underlying disease, not syncope. Non-cardiac cause has a 1-year mortality of approximately 6%. And the neurally mediated vasovagal syncope, the mechanism cause syncope is about 20 to 30%. Patients older than 65 years old. In older adults, vasovagal syncope may be associated with a comorbid illness, increased overall mortality. And vasovagal itself doesn't worsen prognosis. And no cause found in approximately 10 to 20% of syncope patients. Prognosis for those patients no worse or better than that of the general population. For the regarding the pathophysiology of the syncope, the prevention of the syncope. So it's the integrity of multiple interdependent control mechanisms crucial for maintaining adequate perfusion of the brain and the cerebral oxygen delivery after sudden changes in blood pressure. So we all know that the blood pressure is controlled by carotid and aortic baroreceptors, which can further modulate the rest system and further modulate the arterial autoregulation. So if anything wrong with this system, definitely it can cause decreased blood pressure and cause syncope. So that's why we want to focus on these systems. And for the older adults, the reflex system are less responsive. So it has decreased ability to increase heart rate in response to sympathetic stimulation, and the increased sensitivity to effects of dehydration, diuretics, and vasodilator medications. The comorbidities that affect postural response are common, including diabetes, Parkinson's diseases. Medications may further impair postural reflexes, including vasodilators, calcium channel blockers, ACE inhibitors, beta blockers, tricyclic antidepressants. And regarding the pathophysiology to address the causes, so the age-related decline in adaptive reflexes, comorbid conditions, and medications can all have a role in older adults presenting with syncope. So address these issues by increased caution with the postural change, physical counter pressure maneuvers like including like crossing and compression stalking to increase the venous return in order to increase preload. Adequate hydration also increase preload. Simplification of patient medication regimen to eliminate excessive medication to prevent decreased preload or decreased cardiac contractivities. So we have, and also try to maintain the regular heart rate which we have already talked before. And for the syncope evaluation, first we should know the patient history. So the accurate recall of syncope event is frequently inadequate because of the high prevalence of cognitive dysfunction in the older population. Additional history, if possible, should be obtained from a witness to the event. So we should ask, did the patient suffer syncope event like a complete loss of consciousness, or patient just have dizziness or disequilibrium of force, so which is different from syncope. And right now, for common older adults, it's important to differentiate external force from syncope causing force. And also, we should know if patient has any pre-symptoms like eating, urinating, coughing, medication, emotion, stress, physical exertion, or turning head in order to differentiate the different kinds of syncope. And the prodrome, including symptoms like chest pain, palpitations, dyspnea, diaphoresis, pre-syncope, nausea, vomiting, which are which are also a symptoms for the vasovagal syncope. So regarding the medications, we should know how patient take it and when did them take it, and about the dose, and pay close attention to those that can cause bradycardia and hypotension, and relationship to meals, activities, and recent changes of medications. And also we need to pay attention the witness and duration of event. So as we mentioned, the syncope normally less than 1 minute, or seizures about 5 minutes. Appearance of patient during event like flaccid tone and motionless or increased tone and motion, and to differentiate from seizure and syncope. Combined conditions like CAD, diabetes, non-aortic stenosis, all different risk factors can cause syncope. In order to predict the cardiac syncope, here's a score system which is called EGSY score system. So it's if patient has palpitation preceding syncope, a score before, and the heart disease or abnormal ECG, score 3, syncope during effort, score 3, syncope while supine, score 2. So all of these are related to the cardiac syncope. And the palpitating or predisposing factors of both all of the autonomic prodromes are more likely vasovagal or periphery vascular rhythm decrease. Decrease are not related to the cardiac syncope. For the physical examination, we should focus on the cardiovascular and neurological areas if concerns are raised by the history. Blood pressure should be measured in both arms, and the blood pressure pulse should be measured in both supine and standing positions after 1 minute, 3 minutes of standing, in order to make sure the patient has orthostatic hypotension or any other nerves problem, because dysfunction of autonomous of the peripheral neuropathy caused peripheral vascular dysfunction. And also carotid pulse examination, including delayed upstroke and low volume, may identify aortic stenosis. Perform carotid massage only with the continuous ECG and the resuscitation equipment available. So this one, I would say it's pretty tricky. We really do this in the clinic, and also it's relatively contraindicated for patient who has a carotid root, which means the patient has sclerosis in that area. If we do that, it's really easy to break the plaque and cause a stroke. So you definitely don't want to do that. And also, if patient has CVD and recent MI, their cardiac function is not good. If you do this, it can further worsen the cardiac function. So which which may cause a cardiac shock, which is worst. So which you definitely don't want to see that either. And also we can do cardiac examination for murmurs, extra heartbeat, heart sounds, and we call it ectopic heart sounds, or stool or clue blood to rule out any potential bleeding caused the decreased cause anemia and decreased preload. Neurologic examination to assess focal deficits, assessment for cognitive function, visual acuity, coordination, gait, which is also important. And for the diagnostic testing and the following. So in the next slides, we will definitely review the various diagnostic tests that are available for the evaluation of syncope. And it's important to remember that not every test is required. The history and physical are used to guide appropriate testing. In all patients, assessment of orthostatic vital signs, gait, laboratory tests, and ECG are reasonable first steps. So for orthostatic vital signs, and so we should let the patient lie on the bed for like 1 to 3 minutes and measure their blood pressure, and then after that let them to stand up stay there for 1 to 3 minutes and measure blood pressure again. If systolic blood pressure drop of more than 20 millimeter per mercury on standing, which means the patient has orthostatic hypotension. And by doing this test, we definitely need to protect the patient when they try to stand up and just standing in front of the patient. So if patient dizzy and has syncope, they can just fall on your body. If patient fall behind for the back, they can just lie on the bed. So just be careful. And if patient has this problem, just let patient maintain hydration, consider reducing hypertensive medication, and also recommend the patient when they wake up in the morning, sit in the bed for like 3 to 5 minutes and gradually stand up, which can also decrease falls or syncope. And also repeat measurements to identify situations that precipitate orthostasis, including postprandial hypertension. Gait evaluation, like unsteadiness or failure of heart rate, to increase like chronotropic incompetence, and all of this can increase risk of falls, and also indicate some cardiac issue there. Carotid sinus massage, it's kind of reproducible symptoms. I've already talked before. It's contradicted in some patients, and patients with transient systole and carotid sinus syncope may benefit from pacemaker placement. And the laboratory testing, including hypoglycemia, electrolyte disturbance, anemia, occlude heme in feces, increased creatinine. And so this one we should correct those abnormalities, and and also uh, and also help patient to prevent syncope. And the EKG in order to let us know that a patient has any arrhythmias or lung QT, so and a QV which indicate old infection. So it can give us an issue that if syncope caused by a cardiac issue there. And the echo definitely can give us another picture of like if patient has a valvular problem, like aortic stenosis, mitral valve insufficiency, or other problems like left ventricular outflow tract obstruction. This can be treatable and can be identified. Ambulatory 24-hour blood pressure monitor, it can help us to monitor the patient blood pressure and at home, and can identify patterns with variation in blood pressure, including supine hypertension and postprandial hypertension. Holter monitor normally just monitor patient heart rate, monitor heart rate for about 2 to 3 days, and its likelihood of identify cause of syncope is low. So in that case, we should we'd better to use the implantable loop recorder, which put the loop under the skin. So this can monitor patient heart for 2 to 3 years for the arrhythmia. Definitely is more useful compared to the Holter to monitor patient who has infrequent syncope. And also hand-up tilt table testing. This one can identify if patient has a vasovagal syncope, and it's very useful in older adults. Electrophysiology study, and it can induce ventricular it can and can induce VT, and but this one is really limited to use unless patient really have a less threatening arrhythmia or arrhythmia that can or the patient that has a lot of symptoms because of arrhythmia, like a syncope here, or the patient has dizziness, headache, shortness of breath. And also next is validated depression assessment, because depression is also related to syncope. And there's another treatable risk factors for syncope. Autonomic neurologic testing, this can help us to find the autonomic nervous system dysfunction. And definitely the diagnosis primary syndrome of autonomic dysfunction, the demonstrated extent of dysfunction with targets for therapeutic intervention. EEG, it can help us to identify patient have seizure or not. That's for the differentiation test. All right, so next question is if syncope is hospital admission required. So it's really consider hospital observation for patients who has risk factors for adverse prognosis. So patients with no risk factors for adverse events are found to have no significant increase in adverse events regardless of age. A specialist syncope observation unit in the hospital setting has been shown to reduce hospital admission and expedite the diagnosis of a potential cause of syncope. So here are the risk factors for adverse prognosis in syncope, including chest pain, shortness of breath, palpitation of rapid heartbeat, GI bleeding, cardiac history like MI, cardiac artery disease, coronary artery disease, heart failure, hypertrophic cardiomyopathy, pacemaker, defibrillator, antiarrhythmic medications, VT, VF, VFib, syncope characteristics, including syncope during exercise more than one episode within 6 months, family history like family first degree relative with sudden cardiac death, hypertrophic cardiomyopathy, Brugada syndrome, which is popular in the Asian countries, and with 3 different subtypes based on the different EKG manifestations, and also some patients lung QT syndrome, from the history of lung QT syndrome. Physical examinations include tachypnea, hypoxia, sinus heart rate, like bradycardia, tachycardia, systolic blood pressure lower than 90, heart murmur, volume depletion, or deficits, ECG abnormalities, QV, ischemia, heart, ST elevation, or TV changes, vascular ventricular SVT, VT, SVT, AFib with a rapid ventricular response, second, third degree of AV block, correct QT interval more than 500 milliseconds. So here's what's a normal QT interval? Do you know? The male is about 360 to 460, when the female is 350 to 450 actually. So yeah, please remember it, and it's pretty useful in the clinic. Laboratory abnormalities, hematocrit lower than 30% ocular blood in feces. So anyway, so just try to I know it's difficult to remember it. Just to pay attention to the heart. So any symptoms related to the heart, it's kind of a risk factor. And also, remember we talked before, the cardiac output is related to the heart rate and stroke volume, which is further determined by the cardiac contractivities and preload. So all of these factors has a problem, and all the symptoms related to those factors definitely give patients a risk factors. So it's pretty easy to understand if you know those physiologies, and also other. So the periphery the peripheral vascular resistance actually is not that important compared to the cardiac issue. So that's why anything related to the cardiac problem, so the syncope, that syncope definitely will give you a really bad prognosis. So for the treatment, the goal is to improve quality of life and prevent physical injuries. So we should focus on treating the underlying disorder. In older patients, treatment of multiple possible causes is often necessary. Review medication lists for potential culprits. Offer antagonists, clonidine, vasodilators, access diuretics, early discontinuation of medication that increase risk of syncope. And reflex syncope and postural hypotension, non-pharmacological measures with physical counter pressure maneuvers like leg crossing, arm tensing, hand grip, buttock clenching. These all can increase blood pressure by pushing the blood from peripheral tissues into the central circulating system to increase the preload and prevent the syncope. And also compression stockings, abdominal binders also can push more blood to the circulating system. Smaller frequent meals can be effective in patient postprandial hypotension, which can also prevent extra blood stay in the GI system. Medical management, including medogene, alpha agonist, which can increase vasoconstriction and reduce syncope recurrence. But this one should be used with caution because it may cause supine hypertension in those with decreased vascular compliance, and it may exacerbate low urinary tract symptoms due to prostatic hyperplasia and monitor blood pressure response to symptoms. For medical management, pyridostigmine, this one is acetylcholinesterase inhibitor, which can increase both standing blood pressure and the peripheral resistance. The adverse including abdominal cramps, diarrhea, urinary urgency. Use with caution, close supervision. Older adults may not tolerate adverse effects. And beta blockers, this one's pretty tricky. May be useful in older adults with vasovagal syncope, but beta blockers in general population appear to have no significant reduction in syncope. And also, we mentioned that the beta blocker may reduce cardiac contractivities, which may also further worse the syncope during the episode. So I checked a lot of literature, and also they think that the mechanism beta blocker can prevent vasovagal syncope because initially the vasovagal need to have a outside stimulation like some pain or stress or anxieties. Beta blocker like propranolol definitely can help those patients, especially a patient who has a panic attack. So the beta blocker can decrease the sympathetic nerve afferent in order to prevent reflex into the vagus nerve. So another mechanism, it mentioned that the beta blocker can also make the vagus nerve not very sensitive. So which means vagus nerve may not be fired up by the sympathetic nerve system. So it may prevent vagus nerve to stimulate to decrease heart rate, and also the periphery, and also decrease peripheral vascular resistance. So those are two mechanisms. However, another literature published 2019 meta-analysis mentioned that some patients who has COVID-19 and with beta blockers have a high chance to have a syncope, while those patients with COVID infection with ACE inhibitor has no significant increase in syncope. So the mechanism is still unknown. So it seems that it's very, complicated here. And anyway, the mechanism is not very well studied for this. So I would think that beta blocker can probably just help some specific populations, but definitely not for all patients. Okay, so medical management in volume expansion with added or sort of fluorocortisone definitely can increase blood volume and also increase preload to prevent syncope. And also the role of pacemakers is indicated when syncope or near syncope is correlated with bradycardia, syndrome, high AV block, conversion pulse in patients with AFib, slow AFib, medications that may cause bradycardia often used for treating significant condition cardiac conditions. Here's beta blocker comes again. So this one, they think the beta blockers in the cardiac can cause cardiac syncope, dementia as cholinesterase inhibitors, and which is also related to especially the donepezil, which is can cause lung QT, and definitely is can further cause torsade point, which is life-threatening arrhythmia. Risk and benefits of discontinuing these medications must be discussed. So not recommended patient with unexplained syncope for or force without the documentation of bradycardia by using the pacemaker. So here are some public reporting. Syncope while driving is uncommon. Many states have law restricting driving following syncope event. Clinicians should familiarize themselves with local driving regulations pertaining to syncope. So here's a summary. In older adults, because syncope is often multifactorial, important to review the medication list of each patient, as medication are commonly implicated as a source of syncope. Most diagnoses procedures for syncope are expensive and have a low yield, unless findings from the history and physical suggestions to use. Important to rule out cardiac conditions as the cause of syncope as the associated with worse prognosis. Treatment of syncope focuses on treating the underlying disorder, and it's important to know your local driving regulation pertaining to syncope. So here we should choose the test wisely. So don't perform cardiac imaging, like a particular echo routinely unless cardiac disease suggested a history, physical exam, or an abnormal ECG. Don't perform imaging of the carotid arteries for simple syncope without other neurologic symptoms. In the evaluation of simple syncope and normal neurologic examination to obtain brain imaging studies. So here's some questions. So a 68-year-old man comes to the clinic because he has lost consciousness twice in the last several months. His daughter witnessed the second event. She said that the patient was washing dishes in the kitchen when he suddenly said that he felt lightheaded and nauseous. She stated that he looked pale and sweaty and collapsed. The patient remembers feeling lightheaded for about 30 seconds before losing consciousness. He woke within 10 seconds and was back to baseline within 1 minute of the event. History includes hyperlipidemia, prior stroke, Parkinson's disease, diabetes. On examination, blood pressure is 129/78, seated and 119/70 standing. Heart rate is 76 beats per minute. Cardiopulmonary findings are normal, and neurologic findings are consistent with well-controlled Parkinson's disease. He has no new neurologic deficits. Electrocardiography shows normal sinus rhythm with no Q waves. There are no significant abnormalities, and his QT interval is normal. So which following most likely establish the diagnosis? A, table test. B, magnetic MRI test of the brain. C, Doppler ultrasound of the carotid arteries. D, ambulatory loop recorder. Definitely A, because this one is less invasive, and also for this patient, it's most likely patient has some vasovagal reaction here because he has some, let's see, go back. So whenever the patient has a syncope, patient has some prodrome, like he looked pale and sweaty. So it's highly likely patient has a vasovagal there. And so definitely table test can trigger the vasovagal, and it's really useful for the older adults who you suspect the patient has vasovagal. MRI normally don't unless patient has a apparent history of neuropathy or neurology problem or brain or any neurology problems. Doppler ultrasound for carotid arteries normally it's not done unless patient that has a stroke or any other concerns. Ambulatory loop recorder and this patient has some palpitation or other heart issues here. So here's the second question. 73 years old woman is brought to the ED because she had a syncope episode and at her nursing home. She was eating lunch when she suddenly slept over and lost consciousness. Episodes lasted 30 seconds and she rapidly returned to baseline. History includes dementia, CAD, hyperlipidemia, diabetes, current medication including glyburide, HCTZ, atenolol, simvastatin, donepezil. And so on physical exam, blood pressure 116 over 68, heart rate 58, blood glucose 110, electrolyte normal, ECG shows mild, sinus bradycardia, QT interval 550, 540, QS interval of 80, and PR interval 150. So which of all medication should be discontinued at this time? Hydrochlorothiazide, glyburide, donepezil, atenolol. Yeah, donepezil. Remember we mentioned that donepezil can prolong the QT interval. So the normal QT interval in the male is about 350 to 400, 360 to 460. The female is about 350 to 450. This one's 540, which is much longer than the normal level. So definitely we should suspect patient is taking the some medication can prolong its her QT interval. So here's another question. So what's the normal range of the QRS interval? Yeah, it's about one. Yeah, it's about it's lower than 120 seconds. PR interval of 150 definitely is also in the normal range, and the medication can increase PR interval, including atenolol, and so that's all for this lecture. So if you have any questions, please feel free to leave your message, and I'll try my best to answer it. Okay, have a good night.